So these are your results. Most people are drinking water. Okay. Well, thank you everyone again for turning up and joining us for our Centre for Digital Transformational Health's lunchtime seminar. And so for those who are joining us for the first time, we usually run fortnightly seminars between 12 to 1 on Thursdays. So please keep an eye out for our upcoming seminars on our Eventbrite page and the Centre's communications if you're on our mailing list. So this event today is also endorsed for 1 CHIA CPD point. So for those who this applies to, please retain your Eventbrite ticket for proof of registration. And now it's my pleasure to introduce our speaker for today, Dr. Jeremy Goldin. Jeremy is a respiratory and sleep disorders physician and the head of sleep medicine at Royal Melbourne Hospital. He's a former president of the Thoracic Society of Australia and New Zealand. Jeremy has recently completed a Masters of Management as part of the International Masters for Health Leadership at McGill University in Montreal, where he completed a final paper which focused on digital health and potential applications in the Australian system. Jeremy maintains a strong interest in clinical respiratory and sleep medicine together with research interests in digital health. And he's very passionate about driving change in the Australian health system and breaking down silos to improve communication between public hospital and community care and enhancing the transition of care. So today, Jeremy will be presenting on the digital health landscape and opportunities for the Australian health system.
And thanks very much for that, Dawn. Thanks for the introduction. So today I'll be presenting on digital health landscape and opportunities for the Australian health system. As Dawn mentioned, my background is a respiratory and sleep physician, and recently I completed a Masters of Management through McGill University. And my supervisor for my final paper was Jean-Louis Denis, who is from Montreal, and Jean-Louis is he's the Canadian chair for health system design and adaptation, and he's got a strong role and interest in change management in different health systems around the world. So I'll just start off just with a quote. This is from Robert Wachter's book, The Digital Doctor, in 2015. If you haven't read this, I'd really encourage you to read this. But the quote is that we can, in fact we must, wire the world of medicine, but we need to do it with our eyes open, building on our success, learning from our mistakes, and mitigating the harms that are emerging. And this is really important. While there is significant benefit in moving into digital health and digital health platforms, there are potential negatives as well, and we need to recognise those negatives and deal with them. So why is a sleep physician giving a talk on digital health? Well, sleep physicians have been relying on digital platforms for many years. We do home-based sleep monitoring. We also rely on digital platforms when it comes to CPAP compliance. Many of the current CPAP devices have modems and link into cloud-based technology which can be accessed by the sleep physician, and we can determine whether the patient is compliant with CPAP or not, and whether they need to have earlier than previously required reviews. This is just some examples of what sleep physicians do. So we often send our patients out for continuous activity monitoring using what's called actigraphy. This is an example of an actigraph. It's called an ActiWatch. And often we send the patient out for 7 days. Patient returns with the device, we download it, and we receive information when it comes to their activity, including sleep-wake cycles, as well as movement, steps, etc. This is an example of a CPAP compliance platform to remotely monitor patients. As mentioned, patient has a CPAP at home, is using their CPAP. Information from the device is sent to the cloud, and the clinician is able to access the data from that pump and can even change some of the settings on the pump remotely. And sleep physicians also have expertise in understanding continuous physiological data. So this is an example of polysomnography, where we may admit a patient into hospital to monitor their sleep overnight, or alternatively monitor their sleep at home. And over 15 years, I've been looking at the results from these devices. So sleep physicians really learn to understand changes in normal physiology, as well as abnormalities in that physiology as well. And when it comes to polysomnography, the things that we're looking at include EEGs, EMGs, oximetry monitoring. We look at ventilation in the form of nasal flow. We look at EMGs through leg movements. We look at ECGs as well. So sleep physicians are fairly well placed when it comes to digital health and understanding some of those digital health platforms. We also see patients who present with issues that may be as a consequence of digital devices. In this case, this is a case series from Barron, published in the Journal of Clinical Sleep Medicine about 3 years ago. And it identified a series of patients who had developed sleep problems because their wearable device told them they had a sleep problem. So these were people who, prior to accessing a wearable device, were sleeping well. They started using the wearable device, which was telling them that they were waking up at night and not necessarily getting consolidated sleep. And suddenly they thought they had a problem and attended their sleep physician. So today I'm going to talk about digital health. I'll discuss the Australian health system. I'll discuss a number of digital health technologies and their potential problems. I'll touch on Australia's approach to the digital health revolution, how we can capitalise on digital health opportunities, and also talk about barriers to change in the Australian health system and how those changes can be achieved. Some of this is very opinion-based, but it's also based on discussions with experts from around the world, as well as colleagues here in Australia. So just to give you a bit of an outline of the Australian health system, it's probably a number of health systems all put together. As most of you know, we have federal government funding of our Medicare system and the pharmaceutical benefits scheme. Federal government passes on state funding to the states that provide for public hospital systems, equipment programs, aged care. Private health insurance contributes somewhat to healthcare in private hospital settings. And we also have non-government organisations assisting with funding of the health system as well. Overall, on average, the individual contributes about 30% of healthcare costs to their healthcare. So it's not a completely free system. And that's consistent with many of the socialised healthcare systems in the world. There's no healthcare system that's completely free. And as a general rule, in most of the socialised health systems, about 30% of costs are borne by the individual. This slide outlines 10 critical themes in a high-performing health system. It's from Jean-Louis Denis in 2011, one of his publications that was for the Canadian government. And it outlines 10 themes focusing on leadership and strategy, organisational design, and improvement capabilities. And Australia performs very well in at least 9 out of those 10 themes. However, the one area where Australia doesn't necessarily perform well, and nor do most other health systems perform well, is an effective integration of care that promotes seamless transition. So transition of care is a huge problem in many healthcare systems, and digital health is really set up to help with those transitions of care. So I'm going to touch on digital health technologies and their potential benefits as well as their problems. And we'll start off talking about an electronic health and medical records. There are subtle differences in what an EHR is and an EMR, but we'll use these terms interchangeably. But the electronic health record forms the basis of the digital health revolution. It's a platform to store all of an individual's health data. And it does have the potential to capture and store information from wearable devices, incorporating medication prescribing and compliance tools, incorporating decision-making tools, and integrating care between providers and enhancing patient-centred care. As most of you know, over the last few years, the My Health Record has been rolled out in Australia. And where the My Health Record sits at the moment is really as a secondary file. It's not the patient's primary digital health record. It's a file that's able to capture information from the electronic medical records of all the providers that the patient may be seeing. It has little capacity to integrate and utilise other digital health technologies at the moment, but I understand that they are working on that. And there has been a reasonable uptake of the My Health Record amongst the population. Only a small proportion of the population opted out. The big problem at the moment with the My Health Record is that many providers aren't uploading information to that record. We know that outside of the My Health Record, amongst the different providers and the different healthcare facilities, there are differences in their electronic medical records. If you're looking at individual states in Australia, there are some states that are focusing on a universal electronic medical record for their health system, including access from primary care. So for example, in Queensland, they're focusing on an electronic medical record that is a single record used by all their public health services, and all the registered general practitioners in Queensland have the ability to access their electronic medical record. Victoria has gone about things differently, and they've allowed each health service the autonomy of choosing their own electronic medical record, and certainly are benefits, but there's also negatives as well. And I think the negatives, in my opinion, do outweigh the benefits, as this may significantly impact transition of care, particularly in patients who cross different health services. There may also be some problems in community care accessing information from individual health services' electronic medical records. There may be problems with the consistency of management between providers. There also may be some problems with health economics, possibly duplication of care. And my fear is that it may result in a breakdown of care between hospital networks and also with community care. So when it comes to My Health Record, it was important that we roll out some form of health record for the country. But the risk with the My Health Records is its inability to provide the digital interaction that patients seek, is that ultimately those individuals may look for a digitally interactive healthcare experience elsewhere and bypass their My Health Record. And they may not necessarily need to look too far, as at the moment, companies such as Apple, Google and Amazon are putting large amounts of money into the medical space and developing their own digital health platforms. If we move on to wearable devices, smartphone technologies and medication adherence devices, it's important to differentiate between those devices that are targeted at the wellness industry and those that are medical devices that have been approved through regulatory organisations. In Australia, there is an approval mechanism for these devices. So that's through the Therapeutic Goods Administration, and the TGA is a founding member of the International Medical Device Regulators Forum, or the IMDRF. The FDA is also a founding member as well. When TGA approves these devices, it's risk-based. And we know when it comes to wearables, there is potential for significant benefit, particularly in a chronic disease, which is a healthcare priority across the OECD. This is an example of some of these digital platforms, and they cross different diseases. For example, there's online platforms or smartphone apps for COPD, so the My COPD app. Also for asthma, it's the Propeller app. There's a number of apps that are available for blood glucose monitoring, so in the diabetes space, and the number of these apps are exponentially increasing. If you have a look at some of the wearable devices, once again, this space is exponentially increasing, and this is just an example of a few currently available wearables or devices that are able to provide home monitoring. There's the Current device, which can monitor such physiological parameters as oxygen saturations as well as heart rate. We have the Apple the Apple Watch 4, Series 4, which has an ECG that has been approved through the FDA. It's not currently available in Australia. Geisinger Health Plan is really targeting patients who have heart failure and is based on changes in weight day to day. And there's the Cardia mobile device, which is a smartphone-based ECG recording, but there's many of these devices. Many of you have seen diagrams possibly similar to this, but this is the standard discussion when it comes to using telemonitoring and digital health platforms for remote monitoring. That usually there's some form of wearable device that measures various physiological parameters, possibly point of care testing, that is fed into a smartphone app. That smartphone app then feeds the information to a cloud, and there's a healthcare provider at the other side who has the ability to review that data in the cloud and possibly make treatment decisions and decide whether the patient's stable or unstable, needs to come into hospital. In many cases, you can build in red flags within the system, either through the smartphone device or through the overall platform. It is important, however, that the technology will not be successful unless it's used in the right clinical setting. So while we should not only be looking at the accuracy in recording, we should also look at the effectiveness of the model of care, whether it improves efficiency of care, whether it's cost effective, improves quality of life, and whether it's accepted by the doctor and patient, and whether the patient is compliant with the devices, and whether the doctor is compliant in reviewing the information. If you identify the wrong patient group to use these platforms, it potentially sets you up for failure. And one of my big concerns with continuous physiological monitoring is even amongst medical practitioners, there is a lack of understanding of normal day-to-day fluctuations in physiology. So if you look at arterial oxygen saturations, that does fluctuate from day to night to some extent. FEV1 has some degree of circadian variability. Heart rate at night usually drops by 10 to 20 beats per minute. Blood pressure can fluctuate as well. So really understanding what is normal fluctuations and what is abnormal is important, and many healthcare professionals don't necessarily understand that. So just to go through this model and some of the potential issues that needs to be considered. Well, whenever you use a wearable device, you always have to consider its accuracy, but also recognize that these are prone to artifact. So it may be artifact as a consequence of movement, or there may be some electrical interference. And you need to recognize when that artifact is occurring, because if you don't recognize it, you may ultimately contact the patient or ask the patient to come in to receive care when the data that you're receiving is just abnormal data due to the device rather than due to the patient's physiology. There's also differences in how the physiological data is received. So we talk in oximetry about averaging times and sampling rates, and there are certain benefits of changing the averaging rate and the sampling rate of oximetry. We can get into that later if we have some time. And then patient acceptance and compliance is very important as well. If we look at the smartphone device, we want a smartphone device that's effective in capturing data, it's easy to use, and has an ability to interact with the patient. So to potentially provide feedback as well as provide education to the patient. Smartphones should be able to identify abnormalities, but it can be challenging because abnormalities in what's abnormal in one patient may not be abnormal in another patient. So you need to have some form of way of adapting the red flags to the patient that you're seeing. When it comes to the doctors, there needs to be a motivation in using these digital technologies, and the reimbursement issue is a big issue. If you don't have that motivation, it's unlikely that doctors will really accept this type of technology. Doctors need to be compliant in reviewing that data that the technology is taking from the patient, and act on the data that may be significantly abnormal. And then the overall platform needs to have the ability to capture and red flag abnormal data. There's always going to be privacy issues, and there's those user friendliness issues as well. So I thought I'd give a couple of examples of telemonitoring in COPD as well as in paroxysmal atrial fibrillation. So if you think about that model of monitoring patients at home with COPD, you have the ability to monitor their oxygen saturations, their respiratory rate, their heart rate, possibly even sputum colour and quantity, and that can be fed into a smartphone app and then fed through to the clinician. But it is really important to work out which COPD patient you decide to use for your program. Do you want to just use every COPD patient, in which case you're potentially going to identify people who would never have presented to healthcare for minor deviations in their physiology? Do you want to identify the exacerbated phenotype, or do you want to identify those patients who are more at risk of hospital admission? So those patients who may be post-discharge. And then you have to think about what are the thresholds to commence an action plan, or to attend the local doctor, or to attend the emergency department. And you also have to start thinking about what if those thresholds are wrong. So to give you an example, if we set a threshold of arterial oxygen saturations of less than 88% triggers a healthcare response, most patients with COPD, even mild COPD, will drop their oxygen saturations at times to less than 88%, and you may have a flood of patients with COPD presenting to healthcare. On the other hand, if you set the trigger at an SpO2 of less than 85% for more than 4 hours, you may miss those patients who have low SpO2s that don't quite meet that target, who decide not to attend healthcare because their smart device has told them they don't need to. So really understanding those thresholds and where those thresholds sit, also understanding the medico-legal liabilities if you miss a deteriorating patient based on the information that's being fed to you remotely. If you look at atrial fibrillation, so using the Apple Watch 4, so if we looked at patients who have paroxysmal atrial fibrillation, once again, you know, if a patient has a brief run of atrial fibrillation, do they attend their GP? Is it going to cause more anxiety for the patient? Are we at risk of overburdening the health system? So continuous ECG monitoring may not necessarily be useful in a patient who has asymptomatic paroxysmal atrial fibrillation, whereas it may be better used in a high-risk patient, such as a patient who has moderate to severe cardiac failure, who may be at higher risk of cardiac arrhythmias, and early identification of the cardiac arrhythmias will result in healthcare interaction, potentially improving outcome for the patient and possibly reducing costs when it comes to the system. Other devices that are available include medication adherence devices. There's a number of these devices that are available at the moment, including devices that fit onto inhalers, that when the inhaler is triggered, it sends a message to the smartphone to let it know that the patient has taken their medications. There's a pill bottle called glow caps. So when the patient needs to take their medication, the bottle starts glowing and starts beeping. And there's an interesting device, capsule called the Proteus capsule, which basically when the patient takes their medication, the capsule interacts with gastric acid and it triggers a signal that is then fed into a smartphone to let the provider know that the patient has been compliant with their medication. But once again, there are issues when it comes to this, and one of those issues is what's the doctor's responsibility if they're finding that their patient is non-compliant, or if they haven't checked the data that the patient is compliant or non-compliant. Moving on to telehealth. So telehealth is the provision of healthcare remotely. It includes any form of remote monitoring and communication, whether it be through sharing data or communicating through a telephone, smartphone, cloud or video link. It includes telemonitoring, which we've just spoken about. But in Australia, most telehealth consultations are just consultations through video conferencing. There are potential benefits, including access to medical care, the elderly, those living in remote areas and the working population. There's possible benefits in reducing costs in the health system, but there is a possibility it can increase cost. Many of the benefits are highly dependent on the model of care in which telehealth is used. And with COVID-19 and the new telehealth item numbers, it will be interesting to see what the government does post-COVID-19 with those item numbers, because I think some of the phone consultations may not necessarily meet the standards we hope that they set. There are possible reimbursement issues, so difference in reimbursement models from country to country, potentially problems with reimbursement here in Australia as well. And there are clinical issues. So using telehealth potentially affects the ability of establishing and maintaining the doctor-patient relationship. If you don't choose the right patient to conduct a telehealth consultation, you potentially are providing less effective care. Obviously, you can't perform physical examinations as we know them. There are some technologies that are being developed, some have been developed, which provides a home-based physical examination that can be fed back to the doctor. There is a potential for abuse, such as overprescribing narcotics, and there's also the potential for fragmentation of care if multiple providers are involved. So what we're seeing at the moment with telehealth item numbers, patients may have their usual GP, but if after hours they're experiencing a symptom, they may go to one of these very much commercially driven telehealth platforms. There's a number of there's a pharmacy that's performing one of these platforms, and there's other commercial entities as well. And so a person's care may be broken between multiple different general practitioners. There may be some legal issues, so liabilities concerns if you're unable to conduct a comprehensive evaluation and you provide management decisions based on the lack of information due to the telehealth platform. And there may be some social issues as well, including access to technology. There's been plenty of telehealth success stories. Lilly demonstrated reduced mortality, length of ICU and hospital stay in a tele-ICU program across 5 US states. Kaiser Permanente, which is one of the big US insurers in Northern California, has over the last 4 or 5 years really focused on virtual communication between provider and patient. And they found that there was high clinician and patient satisfaction and possibly improved outcome using their model. Rasuli presented at the European Respiratory Society conference in 2018 on a telehealth tool in the management of COPD, and there were significant improvements in quality of life, patient satisfaction, reduced hospital admission, reduced COPD related costs when compared to standard care. So this is just a quote from me. With increasing population health awareness, increasing accessible health information, and those evolving technologies both in the health and wellness industries, health systems are faced with the demands of how to access and use these technologies to capitalise on providing optimal healthcare provision. This is particularly challenging when considering the competing healthcare demands, the diversity of opinion, financial incentivisation, and the organisational cultures which may be resistant to change. I'm just going to touch on artificial intelligence. We're a long way from artificial intelligence, although AI researchers will tell you otherwise. Some AI researchers are optimistically predicting that AI-powered technologies will outperform humans at surgery by 2053. Artificial intelligence relates to how to train computers to do things that humans can do. Machine learning is a subset of AI and involves the computer learning from experience. Deep learning is a subset of machine learning, which involves a network of algorithms to achieve learning known as an artificial neural network. There's widespread use of AI throughout other industries, including banking and finance, airline and aerospace and automotive industries. Most of you are familiar with decision support systems, which we've been using in healthcare for at least 15 years now. They have a significant role, particularly in safe medication prescribing, guideline adherence, risk screening, prognostic scoring. They've been highly effective in reducing error rates. And one would think that moving from a decision support system to artificial intelligence would be easy, but clearly it's not. There are fears that AI will disrupt jobs and impact the doctor-patient relationship and the application of emotional intelligence and judgment in healthcare. But there are potential pros, which include that healthcare professionals will be able to spend time on uniquely human skills, such as building relationships, exercising empathy, and using human judgment to guide advice. If you have a look at some of the publications related to AI over the last few years, they cover a spectrum of medical conditions, including in dermatology, where a machine learning tool was able to differentiate images of malignant and benign skin lesions with performance comparable to a panel of board-certified US dermatologists. In radiology, deep learning algorithms identifying 14 different chest X-ray pathologies had similar performances between the machine and radiologists in detecting 10 of the pathologies, but generally identified these pathologies much quicker. There was a deep learning algorithm able to predict the risk of lung cancer using a patient's current and previous CT scans, with the model outperforming all of the 6 radiologists that were involved in the study compared to comparator. In ophthalmology, images for diabetic retinopathy with neural networks demonstrated an area under the curve of 0.97 to 0.99 for detection. In oncology, the IBM Watson oncology tool can assist clinicians by scanning medical records, identify key information and provide the relevant evidence and treatment options. And there's even AI tools when it comes to mortality prediction. So Weng and colleagues' study predicted all-cause mortality within 10 years based on an individual's demographics, biometric, clinical and lifestyle data. There are potential problems with AI, and most people talk about the issue with bias. The machine learns from the information it receives, and with variability in practice within and external to health systems, and variability in clinical contexts, as well as epidemiology, there's an increased risk of bias with the program. There's issues with transferability across health systems and populations. So the impact of physiological, anatomical and environmental variability between racial and ethnic groups. And there's also issues with medical and healthcare education. So if AI or machine learning takes over the skills of practitioners, potentially you'll weaken their clinical skills. And if anything, you want to have practitioner skills enhanced so that they can identify those cases that fall outside of what the machine can diagnose. Just going to briefly touch on an example in the area that I work in, so the bias in diagnosing sleep apnea in Australia. So 99% of Australian sleep physicians are from a respiratory background. There's a high variability in sleep medicine training. There's a high rate of CPAP prescription for mild sleep apnea, despite a high likelihood that symptoms such as unrefreshing sleep and hypersomnolence are due to another cause, and little evidence that mild sleep apnea can cause harm. So in that environment, an AI program potentially will receive data that pushes patients towards a diagnosis of sleep apnea and CPAP prescription, which may be well and good for the CPAP providers, but is not very good for the outcome of the patient. So how is Australia approaching the digital health information? Well, in 2017, there was an Australian digital health strategy, and there were 7 points to that strategy. That health information is available whenever and wherever it's needed through the My Health record. Every healthcare provider can communicate with their patient and other healthcare providers through secure digital technologies. High quality data with commonly understood meaning can be used with confidence. All prescribers and pharmacists can have access to electronic prescribing and dispensing by 2022. Maximum use is made of digital technology to improve accessibility, quality, safety, and efficiency of care. All healthcare professionals can confidently and efficiently use digital technologies, and the digital health industry in Australia thrives and delivers world-class innovation. There's 4 key themes which revolve around support, help, create, and preserve. So support me in making the right healthcare choices and provide me with options. Help all those people who care for me to understand me and together provide safe and personalised care. Create an environment where my healthcare providers and I can use and benefit from innovative technologies, and preserve my trust in the health system and protect my rights. So what's happening at a Commonwealth level? Well, there is an infrastructure when it comes to digital health. There's the Australian Digital Health Agency, which drives the agenda. There's the NHMRC CRE that provides a research framework when it comes to digital health. And there's the TGA approval process, which we've touched on already. There is a question about what's happening in our universities. In 2019, a Medical Education Leaders Forum spent half a day on digital health, but at the time, and from what I understand at the moment, the Australian Medical Council, which accredits medical schools, does not have a directive for digital health curricula. And when I've surveyed all of the medical schools, with the responses I received from some of those schools, there is clearly a wide spectrum of digital health training within those medical schools, and the same goes for nursing and allied health schools as well. When it comes to what's happening at a local, state, community level, things are quite fragmented. Most GPs and specialists do use various electronic medical records, although things are quite fragmented at both a local as well as a state level. My impression is there's not a strong drive at a state level when it comes to incorporating digital health technologies. So how can the Australian health system capitalise on digital health opportunities? Well, one area that we really need to be thinking about is chronic disease. And one of the unintended consequences of the 20th century success is that modern healthcare systems was born, developed and structured with acute diseases in mind, and it's ill-equipped to prevent, manage and contain costs for chronic disease. So managing chronic disease and reducing costs associated with chronic disease is a key priority across all OECD health systems. Chronic disease accounts for 71% of deaths worldwide, and in Australia, 37% of hospital admissions in 2015-16 and 87% of deaths in 2015 could be attributed to one or more of 8 selected common chronic conditions. One of the things to bear in mind is that the Australian health system operates in silos with limited communication between those silos, and hence that significant problem with transition of care that we touched on before. And that has a significant impact in managing chronic disease. And there are digital health platforms that potentially can unite some of the aspects of the Australian health system to really focus on chronic disease management. In a 2015 Australian Primary Healthcare Advisory Group report, they highlighted that despite the high burden of chronic disease and the economic and social costs, our current health system is not optimally set up to effectively manage long-term conditions, and patients often experience a fragmented system with uncoordinated care, at times service duplication and other times delayed or absent services. So the role of digital platforms in managing chronic disease has been well established. We touched on some studies earlier, but here's a few other examples. Cruz and colleagues have meta-analysis of 26 trials in COPD using telemonitoring, demonstrated improvement in quality of life, exercise capacity, reduced hospital admission and duration. Bashi and colleagues, a systematic review of telemonitoring and telehealth appears effective in reducing heart failure, rehospitalizations and mortality. And Hanlon conducted a meta review of 53 systematic reviews, which included telehealth interventions in diabetes, heart failure, COPD, and cancer. And telehealth mediated self-management was not consistently superior to usual care, but there were no negative results. I think when we're moving forward, we really need to build on the strengths of existing models and similar successful disease-specific and chronic disease models as the basis of not only the standard of care, but a platform to test and launch digital health platforms. Some of you may be familiar with the Healthcare Home program, which is a current program through the Commonwealth Government that will continue to recruit till mid-2022. And it's essentially a general practice-led program that coordinates care for patients with chronic disease. The multidisciplinary care team model in cancer is now the gold standard for cancer management. And that certainly can be extrapolated to other disease entities. And then in Victoria, we have the Hospital Admission Risk Program, the HARP program, which is based on a similar program through Kaiser Permanente and has demonstrated excellent results when it comes to managing patients post-discharge in their home environments and reducing the frequency of readmissions. There are potential problems with digital health platforms. There's a lot of discussion about security, understanding the technology and its use in the system, medicalising the normal. So we touched on physiological or normal changes in physiology over a 24-hour period, and sometimes people don't appreciate that normal variability. They may start medicalising the normal, leading to patients inappropriately presenting to health providers, possibly starting on treatments they may not need. Differentiating effective technologies from potential harmful technologies, fear of the unknown, the loss of clinical and diagnostic skills, impact on doctor-patient relationship and corporate greed. There are some barriers to change. For example, the Australian health system is structured to allow autonomy of providers and organisations to provide patient care while working under the policy and standards of the Commonwealth and individual state and territory governments. And while there's potential benefits of this healthcare structure, there are recognised problems which do affect how the system operates. So there is a competing system between the Commonwealth government-funded Medicare system and the state government-funded public hospital system. There's differences between the state and territories' public hospital systems. There's the independence of public hospital networks within individual states, and there's independence of individual providers and their practitioners, all of which may potentially cause some problems. The four most significant factors that may impact the rate of adoption and the success of digital health technologies in improving efficiency, cost of healthcare and outcome include fee-for-service models, which the World Health Organization has suggested is the most important factor in driving up healthcare costs and reducing efficiency of care. There's the medico-legal implications of not knowing, medical education, and the lack of uniformity in the electronic medical records in the state territory-run public hospitals or in some of the states. So how can change be achieved? And I'm going to touch on a few ideas. So the first is development of a learning health system, and I'll touch on what that is in a moment. Digital health education needs to be a key priority. We need to look at piloting models of care, and rural health networks are the perfect environment to pilot models of care, as often there's a close association between their hospitals as well as community care. We need to capitalise on existing and successful healthcare assets, such as the MDC cancer models and the HARP models as well, and potentially with cancer models, start using the MDC cancer model for other disease entities, with HARP models potentially introducing digital platforms, including wearable devices. So just touching on a learning health system, it's a system that adapts to progressive science, informatics and care culture to generate ongoing knowledge with capability for continuous improvement through collection and analysis of data, creating new knowledge and applying that knowledge to influence practice. In Switzerland, they are developing a learning health system with their aims to establish a bridging mechanism between research, policy and practice, to help build scientific capabilities for health systems and service research, and to develop standards for the management of health information. When it comes to digital health education, the Australian Medical Council needs to include digital health training of medical students as a key priority and establish a curriculum for medical schools. Healthcare providers, however, also should be required to undergo digital health training, possibly as part of their continuing medical education, and hence a requirement for their APA registration. Already the ADHA and some state governments are developing online digital health training programs. And the Commonwealth Government needs to look at incentives to professional organisations to promote digital health, possibly through their national conferences. So there's a number of conclusions. There's 4 slides of conclusions, which I'll go through before I take questions. But just to go through those conclusions, the Australian health system is a complex system where the Commonwealth Government sets the agenda and creates infrastructure to drive the agenda, but it's very dependent on state and territory governments and individual providers and organisations within the system. There does seem to be a fairly robust infrastructure at a Commonwealth level to drive digital health priorities. But digital health education in some medical schools appears to be lacking, with variability in digital health exposure in the different institutions. The digital health landscape includes regulatory approved devices and digital platforms directed towards healthcare, but there are also products that are directed towards the wellness industry, and these need to be differentiated. Electronic health records are providing the platform for the digital health revolution. However, lack of uniformity in the EHR across medical providers and organisations may negatively impact transition of care rather than enhance it. Wearable devices, health apps, online information sites are booming, but the challenge is to differentiate them between wellness and healthcare, and to educate the population regarding the role of digital technologies, including their limitation. But it is very challenging, particularly in this commercial environment. Telehealth platforms may provide opportunities for more efficient and cost-effective healthcare provision. However, this may be dependent on the model of telehealth and the infrastructure used. There are a number of highly successful programs, including MDC cancer teams and HARP and the healthcare home, and these existing healthcare assets are well positioned to capitalise on digital health technologies and potentially be used as platforms to incorporate and trial digital health initiatives and expand to cover other disease entities and healthcare priorities. Rural health networks provide a conducive environment to pilot digital health strategies. In Australia, there are a number of barriers that need to be overcome in order to increase acceptance and utilisation of digital health technologies. So we need to review the fee-for-service models, the lack of digital health education. We need to create uniformity in electronic health records within public health systems, and clarify a clinician's responsibility in following up cloud-based and EHR-based capture of remote monitoring and compliance data. Strategies that may assist in creating and sustaining change include using such systems as a learning health system, similar to what's being used in Switzerland. So on that basis, there's a lot to get through. There's probably 10 talks in one, but happy to take some questions.
Thank you, Jeremy. That was an excellent presentation. You covered a very broad spectrum of digital health growth areas. We have 2 questions on the chat. So the first question is, are there any reports or research on the siloism of the chronic disease care system?
So sorry, so is there any research on the siloism of chronic disease? So I'm not necessarily familiar with any particular research. I'm sure there is. If you look at a number of the various discussion groups, it does seem to be a key area of discussion. It's not a problem that's unique to Australia as well. So silos within health system and how it impacts chronic disease is a problem that is occurring in many health systems that do provide some level of autonomy between government and provider. But there are some countries who are doing very well where the system is very much a unified system. So a place like Estonia has a system that is very much digitally driven, and their outcomes when it comes to chronic disease management is continuing to improve year by year.
Thanks, Jeremy. So the second question is from Daniel, and he says the RMHs will be implementing Epic shortly. Can you comment on the Australian hospital's perception on the effect of EMR in patient-clinician relationships? He did a study in Chile with 100 clinician-patient diets, and the results showed that clinicians perceived it as detrimental, but patients do not. This has been seen in other countries as well.
Yeah, there's quite a bit about sort of the pros and cons of implementing electronic medical records. To some extent, it's also very dependent on the clinician population and their acceptance of change and their acceptance of digital health technology. As you know, yes, the Royal Melbourne is setting up Epic, and it's a lot of work for everyone. I was able to receive my certificate of completion of Epic this morning, and I was worried that I wouldn't actually get through the exam. I was sweating on it last night more than this talk. But yeah, look, a lot of that comes down to education. It's really coming down to a framework of understanding the reasoning behind setting up these electronic medical records, and really having an infrastructure to support the clinicians through the process of implementation. I mean, every time I've been involved in an organisation when we've started to implement electronic medical records, and this is the third time. You know, for the 6 months before and the 6 months after, it's a disaster. But when you look at things 2 years after, everybody will accept that it is the right approach, and certainly patients do accept that as well. I suppose the only thing is that one of the problems also is just getting that face-to-face interaction with the patient, and sometimes when you're typing into the electronic medical record, you lose that connection with the patient, and sometimes you can also not be in tune with some of the non-verbal communication between you and the patient, and so much of the clinical assessment is based on not only what you hear from the patient, but also what you see and what you feel.
Yeah, that's very true, Jeremy. I mean, there's a paradigm shift between this focus of now that there's 3 points instead of 2 in a consult. We have time for, we have about 5 minutes, and there's a few more questions coming in, so we'll try to get through as many as we can. We have a question from Lisa. She says, have you come across any apps for first responder in crisis situations to provide patient profiles in Australia, such as emergency staff and police?
Oh, I can't. I know that there are those apps out there. I just off the top of my head, I can't actually think of any specific app. It is a bit difficult though. It's most of that information is patient driven into the app rather than a healthcare provider providing information. So it's like with let's say with Google and with Amazon who are developing online sort of health records for patients. That ultimately you'll find that patients set up their own electronic health record through Amazon, for example, and ultimately incorporate their healthcare data into that platform with a view that can then be shared with apps that are related to first responders. So I'm not sure of any specific app, but I know that they're out there.
Thanks, Jeremy. So Wayne says, well, thanks for your presentation. I work at RCH and Monash. The hospitals are using different EMR systems, Epic and Cerner respectively. Is it too late now to aspire for digital integration at a state level?
That's a really good question. And I think the answer is yes. And it's a real problem that with the what's actually required to transfer data into these electronic health records and what's required to train is significant. And I think, as I've mentioned in the talk, I think it's a real shame that Victoria has gone down this pathway where different health networks are using different EMRs. I can't see that that's going to change, and I think we've basically left it too late.
Well, there's a follow-on question. This is from Philip. So he says, isn't the answer to standardise data? Sorry, I'll read it from the start. You've made a reference several times to the different EMR systems in Australian hospitals. Isn't the answer to standardise the data that's transferred between primary, secondary and tertiary levels using standards like HL7, FHIR, rather than being over-reliant on the EMR vendor?
It's probably going into an area I'm not overly familiar with, and I assume that that's probably the right approach. My understanding with a number of the different EMR vendors is that they make it a point of not allowing their systems to talk to other systems, so they don't necessarily work very well together. But it's an area of technology I'm not overly familiar with, but I think that point's been made by the person asked the question.
Yeah. This next one's a comment from John Patrick, that the claim of EMR needs to be more uniform. The hospital level EMR usually fails to serve the needs of individual clinical departments who need more tailored systems to support local data elements and workflow. And this is very true for oncology departments. What is needed is interoperability between local systems and hospital EMRs.
Yeah, I'd agree with that.
And I'm just filtering through. Okay, so a question from George. Are we satisfied that the security platforms used at the moment can protect doctor-patient information? Examples like Twitter getting hacked worries me.
Yeah, so in my discussions with many people who've been involved with the My Health record, most people will say that the security concerns probably are unfounded, and that you probably would be more concerned about your health records if held by a GP or a hospital system, which is more likely to be hacked than the essential electronic health record that's held by the government and has optimal security. Look, I don't think anything can be completely secure. There's always a risk. The question comes down to balancing that risk versus balancing that up against quality of care and efficiency of care as well. It's how much risk are you going to take in order to provide a more efficient, cost-effective health service.
It's 1 o'clock now. Jeremy, do you have time for one more question?
Yeah, absolutely. Yeah.
Great, thanks. So from Joanne asks, how do you view the example of the RPA virtual care from New South Wales local health district being able to integrate primary and acute care?
I'm not familiar with the RPA system. So just ask the question again. It's how have they been able to?
How do you view the virtual care from New South Wales local care, health district, and how it's being integrated in primary and acute care?
Yeah, I'm not necessarily familiar with their system. I know there have been a few systems around Australia that have been piloted. Some have been successful, some of them haven't been successful. I think it comes down to what I've discussed in the talk when it comes to identifying the disease entity or the population group, identifying the models of care, and working really, really hard to build up relationships and respect between the different health entities that are involved in that model of care.
All right, thank you, Jeremy. I think, yeah, so we're right on 1 or 2 now. And so thank you everyone for attending our seminar today. And thank you again, Jeremy, for such a comprehensive presentation. So our next seminar will be on Thursday, the 6th of August. We'll have Professor Renato Belamo from the Austin, who will be presenting on the Data Analytics Research and Evaluation Center. So we'll have communications that will be sent through soon. Well, have a great afternoon, everyone. Thanks for joining in.
Fantastic, thank you.